Hi, my name is Shannon. I am a Doctorate of Athletic Training student here at Indiana State, and today we're going to be talking about practice-based research. So, my first thought or impression of practice-based research was do a treatment, do an intervention on a patient, and if it works, great. Tell people about it. If it doesn't work, keep searching. I didn't really have too much of a knowledge of it before. And then this week we did a lot of reading and research on practice-based research and just looking at what it is, what all goes into it, what is the infrastructure of it. And so from the mold article that we did this week, I really like their definition of it, of linking discovery and application research and practice, and networks that require less translation to apply research to practice. So basically kind of bridging that gap between research and practice. I think a lot of times clinicians will see research and they'll think, well, that's just a big lab, like that can't be done here. It's just very impractical. So I think that practice-based research is really just bridging that gap, taking what clinicians are doing in the clinic, out in the field, in the annex, and applying it from kind of bridging that gap between clinic to lab, and putting an outcome, putting clinician or patient rated outcome on it to see if the effectiveness of the treatments that clinicians are actually using. I know also from the Horn article, they said the best treatment for specific types of patients. So making sure that your patient population is very specific. I think you can't just say that doing eccentric hamstring exercises is great for everyone. I think for practice-based research, they want a little more of a specific population. So saying, all right, doing chin-ups for upper extremity strength for baseball pitchers is really beneficial and preventing or assisting in strengthening for a rotator cuff or whatever, anything along those lines. So making sure that there is an outcome tool attached to it, because just saying, hey, I did Graston on so-and-so's bicep and they're throwing really great now, that's not good enough. I think it has to be something a little more tangible. So if you do Graston on a pitcher's bicep, seeing what the patient perceives as like, hey, yeah, my arm does feel great. Or there's not a whole lot of functional outcome tools out there, but assess their range of motion. Maybe if you want, you could maybe do their velocity, kind of just depending on what the problem is. If they're having bicep pain and they're having pain while they throw, but their velocity never changes, or if you do treatment on their bicep and velocity still remains the same, but pain decreases. So it's also the having the patient, if they feel like they're getting better and they're improving with their injury, then seeing if making sure that that treatment, that intervention really is working. So just an idea, or that's just what my opinions and thought of practice-based research. So one of the questions that we were asked for our assignment is try to think of a time when I have utilized practice-based research to solve a clinical problem. So the first thing that I could think of was the last year, I guess almost 2 years now, we were trained on myofascial decompression, and so much of it was about range of motion. So it was pretty easy actually to implement the treatment of myofascial decompression, and then throwing a goniometer on there and saying, hey, your hamstring flexion has actually significantly improved. So using that of myofascial decompression and range of motion, I've used a couple times, and it actually has worked out pretty well. I think I see the biggest, and patients also see the biggest change with hamstrings, having or doing the shoulder of external, internal in rotation, and doing myofascial decompression is a little more trickier. Patients usually, it's a more sensitive area, so patients aren't very voluntarily asking for cups on their shoulder unless they're pitchers, because pitchers love cups. Usually I'll do it more for hamstring range of motion, and as well I've done it for low back, but I haven't done any outcomes with it. I don't measure. I haven't done a patient-rated outcome with it, or use goniometry for range of motion. But I have done it with hamstring, and patient does. They have expressed feeling less tight. But the biggest outcome that I assessed with it was range of motion. And then another example of using practice-based research in my clinical setting is FMS. So I didn't actually think about it until a little bit later. So coming into the softball team, we do functional movement score scale. And the FMS, you get your initial score, and then from there, the weight room is supposed to use those scores to improve upon, know where areas of weaknesses are. Softball, we don't really use the weight room a whole lot, so those scores kind of just sit there. But thankfully, we do have them. So when an injury like an ACL occurs, the patient or myself, the clinician, as well as across the hall in PT, we use those FMS scores so we can use them as a baseline. So I know for one of our girls, she had an ACL tear. She had surgery. As soon as she was able to do activities of daily living, we did FMS scores, see where she was at. She was at she was at a 17, and then we implemented FMS corrective exercises, and so we did those exercises. Try to do them as regular as possible, but when you're in the summertime, sometimes you don't. It's really hard to keep up with your patient. But she said she did her exercises at home, and so we stayed on that. And then when she came back to campus, we had a more regular routine of her doing her exercises. And then we retested a little bit later, and with FMS, she did improve her FMS score from a 17 to a 19. I believe we retested her again before she left and graduated, and she's now at a 20. So improvement has happened with the exercises that were in her ACL phase 3, phase 4 rehabilitation exercises. So doing exercises and that are recommended from the FMS company group, and actually using those exercises to improve upon and see an outcome of greater, better functional movement in mostly in the hips. So it was cool to see that change, and seeing that glute control, hamstring, hip control that she didn't have as well before, and then was able to really hammer down and actually see that improvement. So that was cool. And then the last one is, have I worked with a mentor, coworker, preceptor that engaged in practice-based research? Probably without knowing it. Yes. So at Fresno State, again, with ACLs, the head athletic trainer, she was really into ACL research and reading about ACL rehabilitation, coming back from ACL reconstruction. So she was really interested in that kind of realm. So we did a lot of, I didn't even realize as a student, I didn't realize that we were doing a bunch of practice-based research, but she read a lot about open kinetic chains when you're originally coming out of ACL surgery. So we did actually implemented open kinetic chains exercises right after surgery, and seeing that the quad control was actually greater than the patients who didn't. So we did have a biodex in our clinic, and we used it a lot. And then we also measured range of motion and all those fun things. But at the time, I just thought like, hey, the research is telling us to, okay, let's just do it, and didn't actually think about we're actually being a part of practice-based research. So that was pretty cool. The little things that you didn't realize that you were a part of until you see these articles and you're like, oh wow, that's really cool. I was actually involved in something that I didn't even know I was involved with. So those are fun things. Practice-based research is definitely an interest of mine because it is something that can be applied from all clinicians from every level. I hope you enjoyed. Thank you.